came through the emergency department with COVID. He walked in, and 3 hours later, he was on a ventilator, and we were shipping him out to Virginia Mason. And the thought was he wasn't going to make it. That 4 weeks later, he went home, and that was a welcome relief. But it was a really scary disease for a while. Some people would get it, they wouldn't even know. Others would go from feeling fine to being really, really sick in a matter of hours to days. So when there wasn't much natural immunity or vaccination immunity, it was a really challenging time, I think, to be in healthcare. Then when these terms that we became familiar with during COVID, when we reached sort of critical mass with respect to immunity, then things started to shift, where we really would be the exception to see someone come in really, really sick. Normally now, I think this morning we had 3 COVID positive patients, but that's all incidental to something else they came in the hospital for. So really, it's just kind of like a super bad flu that for the most part we've recognized and accepted that it's just going to be something we're going to have to deal with going forward. I saw some data over the weekend that we've pretty much put COVID behind us, and the CDC actually is going to announce in a few days that the recommendation for a 5-day isolation period, if you test positive, they're going to relax. So it kind of suggests that we are, COVID's not a thing any longer. But second only to the Omicron spike, there's more COVID activity going on right now than I think that was like December of 22. And that's based on wastewater samples where they can actually gauge the amount of disease in the water. So there's still a lot of COVID going around, but there's enough either natural or vaccination immunity that people are doing fine. So we were pretty anxious last year to kind of put COVID behind us and focus on the project and the other needs of our community. Because that's what we were mostly interested in doing. And secondly, we were just sick and tired of the Groundhog's Day approach of constantly dealing with the same thing week after week after week. During COVID, we did keep the planning for the project going, and that was helpful because about the time that everything settled down and we were able to really focus on moving forward was when we were at a point where we were moving from kind of conceptual drawings to design drawings and really getting serious about the project. And that allowed us to keep it on time, and then right when at the end of last year actually launch it. So that probably is a good segue to start talking about the project. Before I leave that, any questions or comments about COVID and your experience? Could there have been, and I hope I don't ever have to use this advice, but I will ask for it. Could there have been something we should have done differently or better? Because we were making it up as we went along and trying to meet community needs as they presented. Yeah.
Kind of a cross between a comment and a question. I was active in the KPTZ radio.
Yeah.
I was active in KPTZ radio, and I would like your feedback on how well that supported the community, and is that some kind of a communication option that we should always use in the future?
Yeah, I think it really did. It reminded. I think what it reminded the community was one of the responsibility that KPTC has to be the kind of the emergency communication vehicle in the community, and just how important it is.
Okay, so it was helpful to
absolutely.
Okay.
Yeah.
And KROH did some of that information sharing as well. I know you're going to get to it, but I'll just ask it so that maybe you can dwell on it. I'm particularly interested in the geriatric clinic and the geriatric support, because I have been requesting for quite a long time for geriatric specialists in the community. So I want to hear that part.
Okay. All right. The project. Why we're doing this? I think there's really two primary reasons why we're investing in this building. One, the 1965 building, which many of you probably sought hospital services in at one point or another. It had outlived its useful life. It was built for clinical purposes, but we had moved all clinical services out of it. In fact, the Department of Health, because it wasn't sprinklered and a few other things, the Department of Health forbid us from providing clinical services in that particular wing. So it was full of administrators and paper pushers like me. The space wasn't perfectly designed for administration, but it had an incredible view, and I was very content in my office that looked over the water. So we had to do something about that space. Included in that space was Aaron Stark's kitchen and cafeteria. The second reason was that we needed more and new clinical space to grow existing services that were expanding and also to introduce new services. Years ago when we introduced dermatology, because when we brought Dr. Hickox back, she came as a package deal with Leah, who was her physician assistant back in Florida at the time, and we were a little concerned that, our projections just show we need one dermatologist. We were a little concerned that Leah, we would have more providers in the community would need. Well, that concern lasted like a week, and then both of those folks filled up, because there is just so little dermatology access all around the region. So now I think we have 4 or 5 providers, but they are squeezed into a small little space, and they need more space. So dermatology is going to almost double their existing space and allow for additional providers. Secondly, OBGYN. OBGYN was in the small little space in the 65 building that needed to move out, and they need more clinic and exam rooms. So they will be in the new space as well. And then lastly, medical oncology. We're going to be moving dermatology to the new building, and they share the 3rd floor with medical oncology. So when dermatology moves to the new building, medical oncology is going to take over the entire 3rd floor, so that we have room to grow for the patients seeing medical oncologists and seeking chemotherapy. And then I mentioned Aaron Stark's operation. We're going to build part of this is a beautiful new kitchen and cafeteria, which is primarily oriented as a special feature for our employees. Aaron is great about recognizing that he wants to create kind of this oasis for nurses and other caregivers to spend 35 minutes during their lunch break eating Aaron Stark food and in a really lovely setting. So we were really focused on doing that, and inside of the building there'll actually be a courtyard that abuts against the cafeteria. So that'll be on the first floor as well. The new services that we are introducing, first and foremost, is the radiation therapy. So we are introducing a linear accelerator, which I'll talk more about later, and partnering with a group of radiation oncologists in Seattle that actually work with all of the Swedish hospitals. So we're going to recruit a radiation oncologist. He or she is going to live in Port Townsend or Jefferson County and be our full-time radiation oncologist. But he's going to be part of the TIROG group. So he feels that he or she has professional colleagues, and also when they go on vacation or are out sick, we don't have to scramble to find a replacement. That the larger group will do that for us. So we've been talking with them for about a year, and they seem like a really, really good values fit. Most of their experience is in the urban hospital. They are really excited about coming to a rural community, and they have been helpful in helping us select the linear accelerator. And more importantly, they buy a lot of these things every year. We buy one, and they were able to squeeze down the price when we told them we were working with them, which, we're talking about a $2.5 million piece of equipment. Every $100,000 counts. So that is probably the service that we are most excited about introducing. In addition to that, we will be introducing a neurologist that we think we have found, and we are hopefully in the final phases of a recruitment process. A pulmonologist will be upstairs, and ear, nose, and throat specialists, surgeons, and a little audiology clinic for hearing impaired patients. We are working on a gerontology plan or a model and when you mentioned the geriatric specialist, that's probably what we will do, because nearly every one of our, by some definitions, every one of our providers qualifies as a geriatrician based on the percentage of their patients that are 65 years or older. So all of our doctors will need to continue to see an elderly patient population. The thinking is that a geriatric specialist can consult with them, and maybe help with medication management, and be a specialist on an elder care. Geriatricians are very difficult to find, but we have launched that process to sort of identify the type of candidate that would be good for us. And we also have some space to expand our hand and plastic surgery program. Dr. Joseph Meyerson is our current hand and plastic surgeon, and he's going to recruit a partner. So the thinking is our goal is to reduce patient outmigration from the peninsula as much as we can. And the first project that we did when we introduced rheumatology and expanded orthopedics and expanded cancer and introduced cardiology is because those were the services that led to the most residents from Jefferson County heading to Kitsap County or King County seeking care. With our electronic medical record, we're able to chart every referral for a case outside of our community. This next wave, ENT, neurology, pulmonology, those are the services that most members of our community are leaving town for. So it's a good match with services our community needs, but also with the volume that they will be financially sustainable, which small little hospitals have to be mindful of. With respect to the linear accelerator, that's mostly a mission-driven expansion, where what we were finding is probably between 175 to 225 patients a year either are seeking radiation oncology or could benefit from radiation oncology. And for those of you who have experienced that is a grind. You're frequently getting medical oncology, chemotherapy, and in some cases seeking radiation oncology, and you're traveling to Squim 3, 4, 5 days a week for 5 or 6 weeks, or Hillsborough or Silverdale or Seattle. So our thought was that if we were to offer comprehensive services, that would be something that the community would benefit from. And secondly, what we were learning is to offer the choice for some members of our community to travel 4 to 5 times a week, an hour each way, was really kind of a false choice. That many of them would say, that's a non-starter, I cannot do that. So the doctor would say, well, your chances of 5-year survival with medical oncology and a radiation oncology treatment regimen is 85%. with just medical oncology or with what we can do here, it's 45% or 65%. But we'll do what we can if we feel you just cannot leave the peninsula for services. I underappreciated that number. I figured if a person was staring down a cancer diagnosis and the doctor said, here's what we can do to make you better, you need heaven and earth to do that. But if you don't have the means or if you don't have the supports system, it's not really a choice at all.